Hi, everyone. We're just going to finish the last section of chapter 3, which is acid base. Get this set up for you. Nice. Get me a laser pointer. All right. Just got finished with fluid and electrolytes and now finished with some acid base information. So don't panic. This is not a formula that you need to memorize. How does the body deal with hydrogen and bicarb? This is called the Henderson-Hasselbalch equation. And basically, if you just look at this and just kind of listen to what I'm saying, just to kind of give you an idea, when we're talking about pH here in this lecture, we're talking about acid base, we're talking about the pH of the blood. So what is pH? When we take a look at pH, it's all this different calculation, this log of 10. But what I want you to notice is we're looking at the relationship between a bicarb and partial pressures of CO2 or carbon dioxide. Bicarb and carbon dioxide. And yeah, there's all this formula and stuff in here, but basically what you need to see from here is we're looking at this ratio right here, bicarb and partial pressure of CO2. Bicarb, we'll see, which is made in the kidney and generally excreted from the kidney. PCO2, which is made from metabolic processes, but can only be excreted through the lungs, okay? So the second part right here, this equation, again, this is not anything to memorize, but what we look at when we see here, we see bicarb, we see CO2, carbon dioxide, then we see some hydrogen, and we see some water. And you see this equation with the arrows going back and forth. So hydrogen plus bicarb makes the bicarbonic acid, which can break down back down into hydrogen and bicarb, or it could break down into CO2 and H2O. So basically what this equation is going back and forth, the body's always trying to strive to keep this pH in a normal, just the pH that's supposed to be a homeostasis pH. And it can, these electrolytes can just move and bind with each other and excrete to keep that pH balanced. So bicarb, again, is much of it is excreted in the kidney. CO2 can only be excreted through breathing it out. We breathe out CO2, so these are byproducts. Water, we can remove water from our body in many ways, we just learned. And we can also remove hydrogen in different ways too. It's combined with the bicarb and combined with the water. So that's all that is. This is not something to memorize. It's just to kind of understand just kind of homeostasis when we talk about pH and how the body continually strives to have a normal pH. Some normal values are important to know. So when we talk about serum, normal values of serum blood pH, you should memorize that it is 7.35 to 7.45. This is a range that is a safe range or a compensated range. But our body's always striving for a perfect 7.4 with this right here and all these different processes that can go on in the body, multiple ones. You can see right here the normal is a perfect 7.4 pH. But anytime our pH is between, in this green area, 7.35 to 7.45, that's a goal. So when somebody becomes acidotic or alkalotic, or you're taking medications, or you're exercising, or whatever it is, and our body becomes acidotic or alkalotic, body's always striving to get into this range, but more specifically to become perfect right here at 7.4. Anything here to the left of 7.4, we consider acidotic. Any numbers to the right here, we consider alkalotic. So if we just kind of think about the compensated range, we don't get too detailed, intricately detailed here, which we will in another class. But right now, any pH that is less than 7.35, just in general, we consider that acidotic. So as the pH is decreasing, that is an acidotic pH. When the pH is increasing, that's an alkalotic pH. The blood is alkalotic or the blood is acidotic, and there's something that's always causing it. So that's something that we'll talk about too. What are causes of acidosis and alkalosis? So basically, we're just looking at carbonic acid right here versus bicarb, and this is just a balance. There's 20 parts of bicarb to 1 part acid, and that's actually a perfect balance. This is kind of like a scale here. So another normal value that's very helpful to know is when we talk about partial pressures of CO2, the range that we want somebody's PCO2 to be in is 35 to 45 with a perfect number of 40. And then the normal range of bicarb, which we look at bicarbs, we can look at bicarbs just with venous blood. When we draw BMPs, you know, you order those basic metabolic panels. As nurses, you look at those all the time. Again, you see on a basic metabolic panel, we see sodium, right, which we've talked about. We see potassium, which we've already talked about. Chloride, which we'll talk a little bit about here, and the CO2. Okay, we continue to get a BNP. We know here we get the BUN, we get the creatinine, which we'll talk about in the kidney chapter, and then the blood sugar right here, which we'll talk about in regard to diabetes. But for electrolytes that we get in a basic metabolic panel, this is what we're looking at: sodium, potassium, chloride, and CO2. So the cations, the anions. And when you're looking at this right here, even though it says CO2, and this kind of gets a little confusing sometimes for nurses, even though it says CO2, we're not looking at partial pressure of CO2. Partial pressure of CO2 can only be, that value can only be obtained through arterial blood gases, okay, for the artery. But when we do BNPs, we're getting venous blood, right? We're doing venipuncture. This bicarb right here is this right here, okay? So CO2 being an indirect measure of bicarb. And this normal range is 22 to 26. Okay, 22 to 26. So we're looking at this as bicarb. Okay, bicarb travels back in the veins with as hydrogen and CO2. That's why this says CO2, but we're looking at bicarb. So if this level is low, meaning bicarb is low, then we have an acidotic blood. If this level is above 26, we have alkalosis. We're an alkalotic serum. So that's a little sloppy, but I just kind of want you to keep that in mind, because when we do look at that lab in the morning, and as a diagnostician, you're going to order this, you need to know what you're ordering and what you're looking at. We're going to talk more about this when we talk about metabolic acidosis and metabolic alkalosis. So let's talk about bicarb and partial pressure of CO2. Bicarb is a base. That's something to memorize. You look at bicarb and you should think base. That will help you. You should think base. If you don't know that yet, bicarb, base. The more bicarb there is, the more base I have, the more alkalotic I'm going to have, okay? The less base I have, the less bicarb I have, I'm going to have acidosis. So this increased base, we get increased alkalosis. Decreased base, decreased bicarb, we have an acidosis. Very important concept to keep in mind. Kidney, so I talked about that. The bicarb is made in the kidney and it's removed. The kidney excretes it. So the kidney is very helpful in keeping our pH in a normal range because it holds on to or gets rid of bicarb. It's one of the many things that it does. There's multiple disorders that we'll talk about that can cause somebody to have a metabolic disorder. A metabolic disorder meaning a disorder that's occurring in the body anywhere other than the lungs. And we have a metabolic disorder which can cause an acid-base imbalance. Long days, meaning that when we talk about the kidney compensating, the kidney has the ability to compensate when there's a respiratory problem. And for the kidneys to compensate, it takes the kidneys a while, 3-4 days before they can compensate. And the kidneys compensate for respiratory problems. Okay, long time to compensate, which we consider days, and the kidneys compensate for respiratory problems. Now the opposite here, we'll talk about PCO2, and when you think of PCO2, you've got to memorize and you've got to think right here, you've got to think PCO2 is an acid. So as PCO2 increases, we're going to see acidosis. As PCO2 decreases, low PCO2, that's going to lend to an alkalosis. So of course that makes sense when you realize that CO2 is an acid. acid. It's primarily excreted in the lungs. Okay, you got to have breathing. We got to. That's how you get CO2 out of the body. It's a normal metabolic waste product. That's how you get out of the body. Somebody's not breathing, they're going to just accumulate CO2. A single disorder causes it. It's a breathing disorder. Either somebody's breathing too fast and breathing off all their CO2, so their CO2 goes down, or they're breathing slow because they're over sedated or whatever reason it is, and their CO2 doesn't come out of their body through their lungs. It stays in the body because the lungs aren't breathing off. So a respiratory disorder is what causes problems with CO2, either an increase or a decreased CO2. And when the lungs compensate by holding on to or decreasing CO2, that occurs immediately. So if you know anything about breathing problems and ABGs, you know that when somebody goes in to any type of breathing problem with hypoventilation or hyperventilation, they immediately have a change in their blood gases. We see changes in PCO2 and pH because the kidneys take a long time to compensate for respiratory problems. So let's just kind of review a little bit because that's a lot for one slide. So respiratory regulation of acid base. So here we have alveolar ventilation. As ventilation increases, and keep in mind, ventilation is breathing. A breath in, a breath out, a breath in, a breath out. That's ventilation. As alveolar ventilation increases, somebody's respiratory rate increases, their depth increases. As that ventilation increases, we're blowing off CO2. So in the blood right here, the PCO2 goes down. If somebody's alveolar ventilation decreases, so let's say respiratory rate goes down, they're oversedated, they have a head injury, whatever the reason is, and oversedation is probably the most common reason, we see a decrease in respiratory rate, a decrease in ventilation. If my breathing slows down and I'm not breathing, PCO2 increases. Again, we're looking at it in the blood. It accumulates in the blood right here. We're not breathing it out. So this is really important to understand when we talk about hyperventilation. When somebody's hyperventilating, increased respiratory rate, CO2 is coming out of the body. So when we measure it in the blood, CO2 is low, okay? If CO2 is an acid and CO2 is low during hyperventilation, hyperventilation causes a respiratory, okay, because it's a respiratory problem. When we deal with CO2, we're dealing with respiratory. When somebody's CO2 comes down because they're blowing their CO2 out, they have a respiratory alkalosis. Why wouldn't they? This acid right here is decreasing in the blood. It's going down in the blood. So hyperventilation causes a respiratory alkalosis. Very important concept to know. Hypoventilation, now my respiratory rate is low, or I'm breathing very shallow, I'm not ventilating all the way down to my bases. CO2 is going to accumulate in the blood because I can't blow it off. CO2 goes up. CO2 means there's a problem with CO2. Anytime there's a problem with CO2, it immediately clues you to there's a breathing problem. It's respiratory because CO2 is the respiratory component. As CO2 goes up, that puts somebody into a respiratory acidosis. Okay, so super important concepts here. If you're kind of confused, just rewind, listen to that again. This should be something that makes sense to you. Memorizing is, you're going to make yourself kind of crazy. Renal regulation. Kidneys control the acid-base balance by excreting either a base or an acid in the urine. So the kidneys can help by excreting bicarb, and we know that bicarb is a base, and it's controlled primarily by the kidneys. Regeneration of bicarb with the excretion of hydrogen. It can either excrete bicarb and hold on to hydrogen, and hydrogen is an acid, Or it can do the opposite, get rid of bicarb and hold on to acid, either one. So the kidneys compensate in that way, but when we look at lab values, bicarb is what we're measuring. This is what we're looking at in the blood, okay? So as the bicarb is eliminated out of the body, bicarb is going down. Bicarb is a base, right? As this base is going down and it's getting eliminated, and we'll talk about the reasons, it's going down, it's getting eliminated from the body, the base is going down, that puts somebody into, because it's bicarb, we have to call it metabolic. It's not a respiratory problem. We're not talking about CO2. As the base goes down, it puts us in somebody in a metabolic acidosis. As base or bicarb increases, if bicarbs get higher or bicarbs are retained in the body, bicarbs go up. Bicarb, we immediately say metabolic. It's not CO2. It's not a respiratory problem. We would have metabolic alkalosis because this is a base, and if base is accumulating in the blood, it puts somebody in an alkalosis. Let's talk about metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Let's talk about all four of the acid-base disturbances next. And this slide will talk about the causes of them. A hallmark sign is a low serum bicarb, okay? So when we talk about metabolic acidosis, and remember I showed you that BNP, I won't write it again, but you know the sodium, the potassium, the chloride, and the CO2 right here in the BNP from the venous blood. When we take a look at that CO2 or that bicarb, a hallmark sign of metabolic acidosis is when the CO2 is low. It should be 22 to 26. We get our lab value back. When somebody has a CO2 right here, which is an indirect measure of the bicarb, we're looking at bicarb, and their bicarb is, let's say, 18, we know they're in a metabolic acidosis just by drawing blood. We didn't even draw ABGs, okay? Metabolic. Now, we're not looking at PCO2. Don't get this confused. This is not giving us a respiratory status. We do need to get arterial gases for the CO2, but this is an indirect measure of bicarb. And so as that's low, as this gets less than 22, just by looking at that, we can say this person's in a metabolic acidosis. It's metabolic because we're looking at the bicarb, and it's low. Bicarb is low, so it's going to put somebody in acidosis. Arterial pH, like I said, 7.35 to 7.45, with 7.4 being in the middle. This is compensation here, and as it gets below 7.35 here, we call it an acidosis. The pH is decreasing. Why is the pH decreasing? Well, look, the bicarb is low. Something's causing this bicarb to be low. So if bicarb is low, it's going to decrease somebody's serum pH. So let's go back to the two causes. When we talk about, there's many, many causes, but the kind of two main groups. There's two things that occur that will put somebody in a metabolic acidosis. Number one, they're losing bicarb. Something's happening in the body and bicarb's getting excreted from the kidneys or the intestine. Bicarb is being lost. Bicarb is being lost. Okay? That's one of the things. The second common reason is there's too much acid. There's too much acid accumulating in the body. And when acid accumulates with the body, the pH starts becoming acidotic. So what happens here is bicarb it combines with hydrogen. Bicarb combines with hydrogen. If you remember that very first equation, it combines with hydrogen. Bicarb starts running out, and there's acid. There's something causing acid in the body. The bicarb can't attach itself to the hydrogen anymore, so all these extra hydrogen ions are going on, and this person has too much acid. I think about it just like anything that can cause acid in the body is going to be a cause of an acidosis, a metabolic acidosis. So let's come back over here, a loss of bicarb. An important thing to remember, especially if you're somebody who's going to be looking at lab work, this right here, we have the chloride and the CO2. A couple things about chloride, because I didn't really talk about chloride. First of all, we know that chloride increases or decreases and does whatever sodium does. It's a big follower of sodium. As sodium increases because of maybe dehydration, chloride is going to increase the same. If sodium decreases, maybe because of overhydration, chloride is going to do the same. Chloride is a huge follower of sodium. That's the number one thing you need to remember about chloride. The only other thing I want you to remember about chloride is this right here. And remember this, chloride and CO2 in this second column right here. As the bicarb decreases, the chloride increases. These have an inverse relationship with each other. So as somebody loses bicarb, chloride increases. And basically what you'll hear that refer to is a hyperchloremic metabolic acidosis. Bicarb is low. Something's causing bicarb to leave the body. As bicarb leaves the body, it's inversely proportionate to chloride. Chloride goes up. Only two things I'm telling you to remember about chloride. This correlation right here, as chloride and sodium, they go up and down together. But bicarb and chloride are inversely proportionate. So we call metabolic acidosis when we know that somebody's in a metabolic acidosis. Because of this, we see this right here, and we're like, whoa, this person's in a metabolic acidosis. But to kind of determine what's going on, is this person in a metabolic acidosis that is due to a loss of bicarb, or are they in a metabolic acidosis that's due to too much acid in the body? And how we figure that out is we have a formula for anion gap. And we determine that, which I'm going to talk about next, if there's an anion gap, that is single-handedly indicates that somebody has a metabolic acidosis because there's too much acid in the body. We need to talk about reasons why, and that's coming up. And I'll just put here, because sometimes it's kind of nice to hear things twice. There's a couple reasons, but one of the most common reason that it goes into a metabolic acidosis because of a loss of bicarb is diarrhea. So your stool is very alkalotic. So we eat food, it goes into the belly, the chyme goes through the small intestine, it's in the belly, it's pure acid, hydrochloric acid. As it moves through the small intestine, the pancreas and those biliary organs, they secrete a lot of bicarb in the gut. So that bicarb neutralizes. As the stool gets down to the large intestine, it becomes very alkalotic. So if somebody's having diarrhea and they're losing all this alkalotic substance, they're going to be in a metabolic acidosis because this bicarb is just being dumped out of the body too fast. Very common reason we see metabolic acidosis in a patient with diarrhea is C. diff. That would be a classic example of somebody in a metabolic. There's other reasons, but that's probably one of the most common. So over here, too much acid, bicarb combines with hydrogen. What are some things that are too much acid? What are things that can cause somebody to have a metabolic acidosis because too much acid is going in the body? We'll talk about those coming up. There's quite a bit of it. But probably one thing that comes to mind, you think about, is a diabetic ketoacidosis, where lactic acid or ketones and acetones are produced, which are acids, and those acids accumulate in the body. So let's talk a little bit. I just want to briefly talk about anion gap. I don't want to get you confused. If you're in the acute care program, we'll talk about this a lot more. We'll get a little bit more detail. But just in general, I kind of want you to know what it is. So when somebody is in metabolic acidosis, okay, here's the thing. We do lab. They come in with whatever complaints, nausea, vomiting, a million things, right? We do lab. We get this BNP back, and we see that the CO2 is low. Say here, 18, like, well, okay, this person, the bicarb's low. This person's in a metabolic acidosis. Why? Well, are they losing too much bicarb, or is there something going on in their body that's causing acid to accumulate? Well, what we do is we figure out a calculation called an anion gap. If someone has a positive anion gap, that's an indication that something is going on because there's too much acid in the body. Then we look at the differential diagnoses that are reasons that somebody would have too much acid in the body. If we do our calculation that I'm going to talk about, and there is no anion gap, the calculation comes out and there is no anion gap, we know that they're in a metabolic acidosis because of this number. It tells us that. But if the gap is negative, then we know that this isn't going on. They're losing bicarb. And then we can see the differences. What are the reasons that somebody would lose bicarb? What are reasons somebody would have too much acidosis? And figuring out an anion gap with somebody with a metabolic acidosis is crucial. A lot of you guys who are going into FNP, you're going to be going into the ER. Well, this happens a lot. These patients come in DKA. And just because somebody has a high blood sugar does not mean they're in a DKA, right? We need to know if they're in a metabolic acidosis. And when they're in a metabolic acidosis, the next step that we do is we figure out an anion gap. And if there is an anion gap with a hyperglycemia, it's very likely that they're in a diabetic ketoacidosis. So this becomes important whether you're going into an acute care area and you're going to be in the ICUs, you're going to be in specialties, or if you're going to be in FNP and you might be working in an ER. So it's something that at least you need to be aware of. Okay, let's talk about an anion gap. Anion gap, for the most part, with this calculation, normal. Anything 12 or under, we would consider normal, meaning there is no gap. No gap. Okay, we do our calculation. It's 12 or under. There is no gap. If there's no gap, we know that their metabolic acidosis is going to be caused by one of these reasons. If the gap that we do the calculation and the calculation is figured out and it's greater than 12, let's say it's greater than 12 here, oops, we know that it's an anion gap. There's a positive anion gap. And then we got to look at the differentials as to why would somebody have a metabolic acidosis with a positive anion gap, and we would look at those differential diagnoses. So here what we do is this formula. So this is a formula that you can it's kind of easy to remember if you think about it. So remember this right here. When we write out our BNP, the sodium and the potassium, again, these are our cations. These are our anions right here. When we look at a gap, what we're basically looking at is we're looking at the correlation between all the cations in the body and all the anions in the body. And guess what? They should be smack dab equal. They just balance each other out all the time. But we can't measure every single positively charged ion in our body, and we can't measure every negatively charged ion in our body, okay? So we only look at a few. We look at only sodium. Some of the calculations will add potassium, but then your number changes, but that's not a common practice, okay? We look at sodium, that's the positive anions we look at, and then we look at chloride and CO2. Those are the negative anions that we look at. So here's the formula right here. We take the sodium, a normal sodium is 140, and then we take the bicarb and the chloride, which is right here. Bicarb normal, 24. Normal chloride is 104. We subtract these negative or these anions from the total cations. Now, again, we're not getting every one of them because we don't draw out blood and we're not going to do that. This is the calculation that we use. And when we do that, and we do this math calculation, and we do the sodium, and we subtract these anions from it, 140 minus 128, 24 plus 104 is 128, we get 12. There's no gap here. Or if it's less than 12, there is no anion gap. So if somebody's in a metabolic acidosis, and there we do this formula, and their anion gap comes out 12 or less, there is no anion gap. They are in a metabolic acidosis, non-anion gap. And what will eventually happen as this bicarb comes down, we'll see that chloride go up because that chloride kind of takes the place of it. If we figure this out and this calculation comes up to be 13 or greater, now I put all normal values in here because I did that for a reason, so you could recognize you know, what the norms are. But let's just say we did do the calculation with this low number 18. If that came out greater than 13, that anion gap came out 13 or greater, we would say this person's in a metabolic acidosis with an anion gap. And that's what an anion gap tells you. Again, you will be looking at those mostly in an acute care setting. Okay, if the anion gap is increased, the clinical situation is generally more acute. Somebody's got a gap, something is acutely wrong, something is going on with them. We've got to take the next step. Causes become very important too. So what causes somebody to have a metabolic acidosis. Here is an anion gap metabolic acidosis. These are causes. These are non-anion gap metabolic acidosis causes. Anion gap metabolic acidosis, we have increased acid. Something is causing acid to accumulate in the body. These are increased hydrogens, right? The bicarb is just getting run out with so much hydrogen, the bicarb can't connect itself to it. There's no more bicarbs, so there's these hydrogens that are just floating around, floating and floating around. So those are increased acid. I think of somebody just pouring acid in somebody's body. That is going to cause acidosis, and that is a reason that somebody would have a gap. The non-anion gap metabolic acidosis is caused by a loss of bicarb. As this base is leaving our body in large amounts, they're going to become acidotic. So that's important to know. So let's just take a look in general of metabolic acidosis, anion gaps. There's an acronym. You may want to know this. Somebody might get asked when you're in your clinical situation. MUD piles. MUD piles is a common acronym for causes. Now, some of these much more common than the other. Probably one of the most common causes of an anion gap metabolic acidosis is this right here. Somebody comes in with high blood sugar and they're in an acidosis. And if they have no gap, if they have an acidosis with no gap, it's not DKA. A anion gap really is the diagnostic tool that confirms that somebody's in a DKA. That's a common reason. Somebody has lactic acidosis. Somebody goes into shock. Somebody's having an MI. They have increased lactic acidosis. That's acid that's just accumulating in the body, That would be a cause of a metabolic acidosis. Another thing that they see in the ER would be something to think about. We have to always keep in mind too. If somebody does have a anion gap metabolic acidosis, we think DKA, we think lactic acidosis, we get blood sugars, we get lactic acids to kind of confirm those. If not, often it's overdoses. Patients come in with methanol or ethanol glycol, which are like alcohols and antifreeze and different types of poisons and chemicals that somebody might intentionally or unintentionally ingest that's going to put them into a metabolic acidosis, an anion gap metabolic acidosis. So again, it's easy to figure out. We get a BNP. We figure out if there's a gap, something is up. We've got to take it one step further. So methanol, uremia, basically uremia is as somebody kidneys fail and their urates and their azotemia increases, it could put them in a gap as well. INH is an antibiotic that we use for tuberculosis, iron, salicylates, which are aspirin, that could put somebody into an anion gap metabolic acidosis. But like I said, most of it is an overdose of the methanol or an ethanol glycol, a DKA, lactic acidosis. Those are some common things. That should make sense. Like, make that make sense to you instead of just memorizing. I'm not going to, ask you to memorize every single one of these, but do know that a DKA, a lactic acidosis, and a methanol or an ethanol glycol would cause an anion gap metabolic acidosis. Those are the common things we see. What about somebody who comes in and we do a BMP and they're in a metabolic acidosis and we're like, well, their gap is fine. We figure out we got the sodium and we subtracted the bicarb and the chloride and we got 12 or less. There's no anion gap. Well, guess what? None of this is going to be the diagnosis then. It can't be if they have no gap. Bicarb is dumping out of the body. There's not anything in the body formulating acid. Bicarb is dumping out of the body. Number one right here, diarrhea. For you diagnosticians that are going to be in the ER, you really kind of need to think, if the person's not having diarrhea and they have a non-anion gap metabolic acidosis, you kind of got to think it a little bit step further. Renal tubular acidosis would be another differential diagnosis for a metabolic acid, non-anion gap. Carbonic anhydrase inhibitors, which is acetazolamide, sometimes, which is more of like a diuretic that can be used because it blocks bicarb reabsorption. Meds, different types of meds, that one in particular can cause it. So again, you need to think about what is the next step when you see that metabolic acidosis on your BNP. Treatment, here's the treatment right here. treat the underlying cause. There's multiple causes. Generally, if there's some kind of a poisoning or something, we can go ahead and give some fluids, DKA. They're uber dehydrated. We'll talk about treatments for those coming up. This is just a little picture kind of giving you an example of really what's going on in an anion gap. So think about when we talk about an anion gap, what we're talking about. So we're measuring the sodium, which we know is 140 milliequivalents. And then we're comparing it with the bicarb and the chloride, which are the anions right here, okay? But we know when somebody has a chloride of 104 and a bicarb of 24, which is the perfect number, and 140, which is a perfect value for sodium, it's really not even. This is really what it looks like. Like this is normal right here. So when you say gap, do you see this right here? This 12 takes into account this right here, because we're not really measuring another ion right here that's 12 milliequivalents that would actually make it even. So by putting this 12 in the equation, it makes these all even, 140 on this side and 140 on this side. That's all that picture kind of shows. Okay, that was long. Let me go ahead and break here. And oops, I'll go ahead and give you a little break here, and then I'll do a part 2.